Okay, so this was originally not my talk, so anyway, I'll present it and hopefully I'll do some justice. So we'll talk about post-refractive eyes. So corneal refractive surgery alters the basic assumption on which the biometry for IOL calculation is based, which is a perfectly symmetrical nature of the cornea. With the rise in popularity of refractive surgery, which we've been doing for a few decades now, there's an increasing number of patients with a history of laser vision correction or incisional refractive surgery which need cataract surgery. So many of those patients are now coming with cataracts, and as we know, myopes do develop cataract earlier. So they would even come in their late 30s or 40s with cataracts. And there are two complicating factors here. One is that these patients have an extreme of axial length, either high myopia or hyperopia, for which a refractive surgery has been done. And then the corneal shape has been altered, so your keratometric calculation and effective lens position goes out the window because of the alteration that you've done with the refractive surgery. So you have difficulties in IOL power calculation, you have difficulties in selecting the type of IOL. We recently heard about the case of Shah Rukh Khan, who had a major problem after his cataract surgery, and that was essentially because he had a hyperopic LASIK and the surgeon had put in a negative aspheric IOL. In such a case, actually you would want to go for either zero aspheric or maybe a positive aspheric lens, which probably was overlooked. So it's important to choose the lens according to the refractive surgery. Post-operative visual acuity is again a very important thing in these cases because they are post-refractive. They are used to unaided good vision and they expect the same thing after the cataract surgery, and if you give them anything lesser, they'll feel that you didn't do as good a job as the first LASIK surgeon, and they will always be unhappy, how much ever you may tell them. And of course, these eyes are always prone to surface problems and dry eyes, and you have to deal with that as well. So what are the sources of error? One is the formula error. Virgin's formulas use K to estimate the effective lens position. Flatter Ks lead to underestimation of the ELP and vice versa. Keratometrics index error. Standard keratometrics index of 1.3375 is based on the constant anterior posterior ratio of the cornea, which is obviously altered, especially in ablative refractive surgeries. In incisional refractive surgeries, that ratio is still preserved, and this tends to overestimate the corneal power by 1 diopter for every 7 diopters of correction of refractive error. And instrument error, most of these take keratometry from a 3.2 millimeter zone, missing the central effective zone. Flatter the cornea, greater is the measurement zone, hence greater the error. So this is just a diagrammatic representation of post-ablative versus post-incisional refractive surgery. So as you can see in the incisional refractive surgery, there's an alteration of both anterior and posterior curvatures of the cornea, whereas in an ablative, the posterior remains the same and you're only altering the anterior. So the ratio between the anterior posterior is significantly altered in them. So if you had a hyperopic ablation, then you cause a central flattening and a positive spherical aberration with a smaller angle kappa. And if it's a myopic, I mean, and if it's hyperopic, it's a central steepening, negative spherical aberration, and a larger angle kappa. So all of these result in either underestimation of the IOL power in a previously myopic correction or overestimation of IOL power in a previously hyperopic correction. And this is essentially what we are trying to avoid. And there have been loads of formulas, as you can see. There are almost 25-30 formulas which have been described for correcting, for getting accurate IOL calculation in post-refractive eyes, which are based on several things like history, changes in manifest refraction without prior data, and other formulas. So I will just run through some of the important ones. Rather than understanding how each formula works, I think for us, a lot has been made easier by all these online tools that are available, and we are clinicians, we don't have to waste time as long as we know what to take from that and how to apply it appropriately. I think that is more important. So how can we obtain the true, so problem is in the correct corneal power, which is being altered because of all these reasons which I just mentioned. So earlier we were using the clinical history method, in which we use this formula Ka is equal to Kp plus Rp minus Ra, where K is the estimate of the corneal power after surgery, which we want to calculate. Kp is the actual measured reading before surgery, RP is the spherical equivalent before keratorefractive surgery, and RA is a stable spherical equivalent which who should have been hopefully documented after surgery. In this, sometimes you may have questionable accuracy, you may not have documents, you can't really go on what the patient says, you know. They will say 3 diopters, but it may have been 3 diopters with 2 cylinder, and that totally changes the spherical equivalent, you know. And not suitable for RK because of the unstable corneal power, as we know. It keeps changing in RK patients. Contact lens over refraction method is a very useful method described by Ridley, in which you use this formula, which is K is equal to BCL plus PCL plus RCL minus RNOCL. So BCL is contact lens base curve, PCL is contact lens power, RCL is contact lens over refraction, and RNOCL is the spherical equivalent of the manifest refraction without a contact lens. Now, you have to, of course, go put a rigid lens over the patient's eye to be able to do this, and which is a bit of a cumbersome thing. Disadvantage is the accuracy worsens when the vision is less. So if you have a dense cataract, you can't really get much reliable readings with this. Topographic based post-LASIK adjustment. So you can use the central topographic readings from the topography and use Koch and Wang formula. You can use TMS system or some other systems which are available. The newer tomographers, OpScan, Pentacam, etc. will give you information of both the anterior and posterior corneas. So these are especially useful when refractive data is not available, because they can measure both anterior and posterior curvatures. So OpScan is a little less reliable. Pentacam and the IOL Master 700 are definitely better tools if you have them. And a double K correction method using the Koch and Wang nomogram adjustment significantly improves, and it is useful for SRKT, Hoffa-Q and Holiday, not suitable for post-RK. Haig's L formula is a built-in software in the IOL Master, which uses the regression approach based on statistics, based on LASIK data, and only suitable for post-laser vision correction cases, not for RK. And basically it applies a correction curve to the existing measurements to derive the effective corneal power, which you can then input into your which is then inputted into the Haig's formula and the IOL powers calculation. Similarly, recently they have also developed a hyperopic version which also works reasonably well, and it's a useful tool, because in these cases we always used to struggle earlier. Now, ray tracing machines are now available which actually avoid the formula errors, and basically they calculate the refracted ray at both the anterior and posterior surface, and are supposed to be very, very accurate. I don't have much experience with these, but some of the machines like Sirius, Galilei and Oculix and iTrace barometers, you can use these. So Pentacam uses this EKR power map. You can see these two graphs. This is the ideal EKR, which has a narrow base and a single peak, whereas if you have a very wide base, then it means that the keratometry is irregularly distributed, and you may not get a very reliable value in this. And basically this is a map which gives you an equivalent K reading, which you can then input into your IOL formula. For both myopic and hyperopic LASIK, a 4.5 millimeter optic zone, the zone calculation for the EKR is quite useful for the calculation. So we have this ASCR's online calculator, iolcalc.org, and that really makes our job easier. It uses various formulas, as has been mentioned here. And if you go to the website, you have 3 tabs: prior myopic LASIK or PRK, prior hyperopic LASIK or PRK, and post RK. So depending on your case, you select the tab, you input the data from all your different machines that you may have, Pentacam, optical biometry, manual case, etc., etc. And whatever input and clinical history if you have, and whatever inputs you have given, based on that, whichever formulas are applicable in this website, it will give you the output. And from those you can choose. So I think it makes our job easier. We are clinicians, we are not physicists, and you have to fill in this thing, and it will give you an output. In general, I always, in myopic errors, I try to go with the highest corneal, the IOL power that is available, unless it's a very big outlier. So always err on the side of more myopia, and it's okay to end up with myopia than hyperopia in these post myopic refractive surgery eyes. Post RK is a totally different ball game. Do I have time? So here the ratio between the anterior posterior is greater in the central zone and smaller in the paracentral zone when compared to normal eyes. And there's a lot of element of irregularity also, because these are manually made cuts, so the cornea is not very uniform. And third problem is there are diurnal fluctuations. The K values change from morning to evening and over a period of time. So that gives us a lot of problems. Second problem is with the optic zone. It is often less than 3 millimeters, and we usually calculate our Ks from around that optic zone. So if it will actually come at the junction between the flat and the steep cornea, the so-called shoulder, and this results in an overestimation of the corneal power, and you can end up with significant hyperopic surprises in these cases. So we always target myopic in post RK. If it's a 8 cut, go for a -1, 12 cut -1.5, and 16 cut, aim for -2. How to measure the K values basically that's what you are trying to do in both post LASIK and post RK. You can take central measurements, you can actually put your cursor in the center of the cornea and take multiple readings, and this can be used, but it's a little cumbersome and not very accurate. Post RK IOL formulae are available, which basically again are double K formulae. Use various formulae like SRKT, Holiday, and Hoffer-Q based on the K value and axial length to determine the effective lens position. So pre-RK Ks are used for the ELP correction, and post-RK Ks are used for the corneal power correction, and you can use the true K RK algorithm, DK Holiday IOL Master algorithm, and Potwin Hill. In the ASCRS calculator, it uses the effective refractive power, which is basically taking all points from the central 3 millimeters, and these are applied for the IOL power calculation. If you have an Atlas topographer, it takes the average powers from the 1, 2, 3, and 4 millimeter rings, and basically it's again using central corneal power. And if you have a IOL Master lens star, it uses the double K modified Holiday 1 formula using a pre-op K of 43.86 and post-op mean K from the IOL Master or the lens star. So the true K formula is probably very useful especially if you have history, clinical history. So either complete history or partial history formula is preferable if you have historical data. If you don't have refractive history, then you can use the true K no history or the Haigis formula, where the ELP is calculated using axial length and anterior chamber depth. OCT is another tool, especially if you have the OptoView OCT. It can give you the net corneal power calculation using the OCT readings as well, and I use this routinely in my clinic, and I found it to be quite accurate. So and then once it calculates the net corneal power, you can input it into your whichever formula you want to use, and there's also an Excel sheet in which you can just input your data and it will calculate the K value to use. Finally, as Dr. Vinita had mentioned earlier, you can do, whenever in doubt, do an aphakic refraction, and then you have various formulae which are available for aphakic IOL calculation, and you can use that data to kind of calculate the lens power in very cases where you're suppose you're getting a lot of disparity, or your cornea is very irregular, you're not sure what kind of result you're going to get. You can do that. You can do intraoperative refraction, or you can do with a gap of 1 or 2 days and put the lens in.